have a serious melanoma, usually the nodes are white. They are white sometimes. You see there's a bleeding here. There's a node video. We can skip this maybe. We can go forward. Yes, it's a tire. You need biopsy on the visceral floor because you have nodule on the visceral floor you can take. You don't have to be afraid by nodules. But with coagulating forceps, you don't have to apply coagulation. You have to make the difference between the nodules on the surface of the lung and lung biopsy. The nodules on the surface of the lung is not a lung biopsy. You can easily say, even with the optical biopsy forceps without second biopsy, you say, you just have to bring a visual control, you just very careful. No, actually, if you have a gentle approach, you cannot. But if you have an early, you shouldn't have. Sure, but if you have, it's not a big deal. Very small wall. You can do the second one. You take the coagulating process and you apply the superoscopic on the right, on the early, great right, and you can coagulate. We do. So tomorrow in the afternoon, I create early and bleeding for you. Usually I do this at the end of the procedure, just for you to manage this. Not sure I do this. The last afternoon, dedicate to the complication. I make bleeding in percostal space. I make early on the lung, and I ask the attendings to coagulate, close the wound, etc. They're very happy when you can. Yes, you have to be careful. You don't have a for sure. And then at the end of the procedure, diagnostic procedure, you can remove the chest tube on the table. And we do it. Don't worry. Not good. Actually, it's our students who did this. Because, yes, because we ask students. Unfortunately, when the people are referred from the emergency room with chest tube or pneumonia, and you upset, upset. Okay, you can finish. Okay. I asked the student, I showed the student to remove a chest tube by yourself, alone. Because the chest tube has to be removed alone, no two people. It's easier alone. Because when you have two people, one pull the other weight or the other switch and you are inside and it's not alone. Like this. We do the same thing in the world to remove a chest. Same, absolutely the same. Didn't change in 3 years. But the problem, the message for me is because we are very, very busy as you, but we are very busy in the world, the nurse are busy, chemotherapy, everything, the chest tube, etc., etc. The main point is if we can make the nurse job light, it's better. It means if you don't need a drainage, you remove the chest. And diagnosis has already been done. Anybody, you can. If you have a patient in general anesthesia, he has to go to the recovery room. During the recovery room, we get the chest X-ray. But on the table, no. No examination, pure examination is something important. No, 100%, 99.9%. Actually, if it's not re-expand, completely re-expand, what's happened? You have created the pneumothorax. It means that this visceral pleura is healthy. same day. It's not a big deal, you know. It's not spontaneous pneumothorax. Or spontaneous pneumothorax, the problem is here. Or here. I don't know. Porosity of the pleura is different. But you have created the pneumothorax, and consequently, nothing can happen. I remind you that 50 years ago, the treatment of tuberculosis was pneumothorax, collapsotherapy. And the problem was not respiratory failure. The problem was that you have to maintain the pneumothorax because you have the expansion of the lung. It's the same. Are you agree? Are you agree? What do you mean? No, I talk about perfusion in this case, diagnostic thoracoscopy. I don't talk about calpudouage. When you apply sympathetic, when you apply calpudouage for recurrent malignant perfusion, you have to keep the chest tube in the pleural cavity in order to drain, because there is a study carried by Richard Light showing that in experimental animals, the beginning of the fibrotic process is around 72 hours. The reason why usually for pneumothorax we keep in place the chest tube 3 days, and for pleurisy, for recurrent pleurisy after pudouage, we try to see what's happened when there is less than 200 milliliter per day drainage, you know. Okay. No, it's too easy. It's not our job. It's not our job. And you need the lung breathing, in particular, for sure, when you perform lung biopsy. For sure. You know why? Because before doing a lung biopsy, we ask the anesthesiologist, in this case, patient under tracheal intubation, to inflate the lung. Because you know, if you have, for instance, a telectatic lung, you take a lung biopsy like this. When you re-expand the lung, the wall is like this. Then, never take biopsy from the purple part of the lung. Big part, always. We ask the anesthesiologist to inflate the lung. And when you have a very nice lung, pink lung, and you, on the surface of the lung, you can grab the lung and you make a wall like this or something like that. I'll show you tomorrow. It's true. It's a real, yeah, it's true. But you can, in this case, you can using the double balloon insufflator. You can, under visual control, insufflate air very carefully, and you push the lung with air. Insufflate your air into the pleural, but under visual control. Because the problem can be, of course, to have a high pressure on the mediastinum or something like that. But you can, okay? But the first step of your procedure is when you induce artificial pneumothorax, you induce water, you hear the air going to. And then you leave the needle in place and you prepare everything. You check that everything is okay. And during the patient kept in spontaneous breathing, you can easily manage this, you know. And then you have inspiration, expiration. You have a balance between the atmospheric pressure and intrapleural pressure, which is the same at that time. And sometimes, in most of the cases, you have a good collapses of the lung, not too important, but enough to make a careful analysis of the pleural cavity. The reason why we prefer to perform thoracoscopy, keeping the patient in spontaneous breathing, because it's more useful. No, in our experience, no, but you can. It's not a big deal. We have facility for that. You know, French are maybe a little bit sensitive, and then we have to be careful of the French, the boy in particular. Sure, I do. Of course, you know, when I'm in hurry, I ask the nurse to come with me, right? without student, without fellow, without nobody, and I perform thoracoscopy, take 10 minutes, to deflate the lung, take a look, carefully, remove all the fluid, put the optical biopsy portion, you take 20 specimen, put the chest tube, expand the lung, remove the chest tube, that's it. And you discuss with the patient, is everything okay, good, etc. But in this case, I use only local anesthesia. I mean no neurolephalangia, nothing. You can do, because in case of malignant distribution, most of the cases, the pleura is very sick. It's not so painful, actually. But you can apply pain control medication, of course, just before your procedure. Or now it's true that some teams, for instance, my friend from Nice, etc., use midazolam a little bit. You can put 1 milligram midazolam, it's okay. Okay. But in France it's very strict. The pulmonologists have not the right to use anesthetic drug, and midazolam considered as anesthetic drug, which is a problem. Of course, you can do whatever you want, but if you have a problem, it's a big deal. Yes. Yes, we follow the patient. We follow the patient. It depends on your suspicion, We were discussing concerning the asbestos exposed patient, for instance, because it's a main point. Usually, in Marseille, we have less than 3% of our procedure without diagnosis at the first procedure. Less than 3%. It's very low. Very low. But these 3% are mainly asbestos exposed patients. We have also patients with collagenous disease sometimes. But when you have asbestos exposure, there is a regulation in France for the survey of such patients. For instance, we have a national network concerning mesothelioma. I'm the head of the national network concerning the clinical approach of such patients in France, and we have regulation, 3 months, 6 months, etc., etc. But you do not have to hesitate to redo thoracoscopy if there is a recurrent disease, in particular if the patient is, progressive, no. Actually, if your question is, do our policy is to perform prosthesis in case of evident malignant aspect of the pleura, our answer is not. But we have a reason for that, because we check chemotherapy, the efficacy of chemotherapy by CT scan, but also we do thoracoscopy. But I know that most of the team perform calpoudrage on the first thoracoscopy procedure, which makes sense. Why not? No. You don't do. You expand the lung, you remove the chest tube, and you discharge the patient. You say, I want to see you in 1 month, and you have to follow your patient. Yes, if you see later, you did the main point. You did a careful examination of the pleura cavity. You sample the pleura because you have non-specific inflammatory aspect of the pleura, which is a point on the mouth. And then you did the job. If the pathological answer is malignant, you have the diagnosis, and you have the evaluation of the pleura cavity. Parietal pleura, visceral pleura, etc. You have everything to manage the patient. Sure. Yes, sir? It depends. Actually, I welcome a lot of people from other countries in Marseille. Our fellow, for instance, at the end of the thing, it's a 6 months, 6 months, 6 month training. It changes each 6 months. At the end of 6 months in the world, no, every fellow, no, perform thoracoscopy. Every fellow enrolling in our world, of course. but the other two, because it can circle. May I have an interesting case? May I perform thoracoscopy with you? Yeah, you do. I have to. Don't worry. It's okay. No, no. Please, keep easy. It's very simple, because I can tell you. The problem is a state of spirit. It's a psychological barrier. Again, we can tell you. Uh, it's, you mean, for instance, breast cancer patient, etc.? Breast cancer patient, etc. It could be a problem sometimes. The reason why you have to very carefully check the pleural cavity before doing thoracoscopy by CT scan. And in this case, if you have, because if you perform thoracoscopy, it means that you have fluid even after radiotherapy, and then you have to check the pleura to see if there is adhesion or not. And for such patients, sometimes we try to induce the artificial pneumothorax the day before. But you know, if you have 1 liter, 1.5 liter in the pleural cavity, you know that the pleural cavity is free of adhesion, mainly. You understand? But it's an important point, because we have plenty of patients with pleural effusion after radiotherapy, because it can happen. It can be induced by radiotherapy, even very late, 6 months later, etc. No, for the patient who undergoing radiotherapy for breast cancer, the axillary lining, it's not a big, not hammer. No, it's always possible. You have to, maybe your point of entry will be a little bit lower than usual. I mean, 6 intercostal space, you have to check carefully, but it's not a big deal. The problem is not, it is a skin, it's not the pleura. It's the skin, it can be a little bit hard, but yeah, it is. Oh no, that's stories. No, radiotherapy for breast, it's around 45 gray. At the beginning, it's no more than 60 gray. You can answer it. I don't know. I'm not general oncologist. I'm just a care of lung cancer, pleural cancer, etc. I'm not. It's not my job, but no. It's the same. It's the same, for instance, after radiotherapy for lung cancer, and you know, the majority of these patients have pleural effusion. What are the difficult cases? The difficult case is that you can enter into the pleural cavity when you have pleural adhesion and amphiedema. I think it's the most advanced level for thoracoscopy, but I think at the beginning, pleural effusion in the motoracus is an easier one. The problem is just if you have you cannot create artificial pneumothorax, is the point. Otherwise, when you are into the pleural cavity, it's not a problem. Yes, in case of pleural tumor, without fluid, yes. But we used to create the pneumothorax the day before, in this case, just to see, because usually in this case you have the tumor. Sometimes it's a pleural tumor, but it can be also peripheral lung tumor, with chest adhesion, and then it's interesting. It's a very interesting thoracoscopy usually, and we create the artificial pneumothorax the day before, as you will do tomorrow for the animal, without food, without nothing, and after you perform chest X-ray in order to see which point of entry is more relevant for the point of. Yes. Yes.
Open surgery. Is it possible using, like you showed us, the coagulation forceps and inducing pneumothorax in these patients the day before to go in with the thoracoscopy and take a lung biopsy using the coagulation forceps? It's okay? Or is there a risk, because usually these patients have a lot of air spaces in the lungs that can that could rupture or...
No, actually, it's possible. You have the nice study by Van der Kist did this job in social lung disease. But usually for this patient, there is no addition. It's very rare. You can create a pulmonary on the table if you want. If you are really scared to induce pulmonary the day before in such patient, for instance, I think you can do on the table. What is the risk? The risk is to not induce pulmonary. No, I mean the technique of the thoracoscopy in this case. The problem would be that you cannot induce artificial pneumonia. That's it.
No.
You awake the patient and you tell him it was impossible and I have to refer you to the surgeon because he has a different tool than me.
So it's an indication.
Oh yes. But you know, the problem is the indication of thoracoscopy the biopsy decreased dramatically since we have a very performed last generation CT scan, etc. now.
Okay.
And we can see very properly UIP, NSIP, etc., COP, etc., etc. And then the indication of lung biopsy decreased even for the surgeon. Even for the surgeon, because if it's too late and the answer is non-specific fibrosis, or if too early, late generation CT scan can approach the diagnosis, and sometimes at the end it's steroid. You understand? And then it's very rare to need lung biopsy. It's the reason why. But my take-home message is you can touch the lung. If you have another of the lung, you can take. If you are not comfortable, if you have the coagulation process, you perform second point of entry in order to be safer, if you feel safer, and you take with this cognitive process, with or without coagulation. It's not a problem. We saw tomorrow. I think it will be clear for you. Maybe more. You mean how long we keep the chest tube in prolonged bubbling, for instance? Yes. In Marseille, after 7 days, we stop. We remove the chest tube and we see what's happened. If it's trap lung, if the patient is okay, if it's pleural cancer, etc. We stop at the end. Sometimes now we have in-wheeling pleural catheter, which are good in this situation. You can put a Purex catheter or a Furman catheter, for instance, ambulatory drainage. But the problem is in France, in particular near the Mediterranean Sea, I don't know in Egypt, maybe it's the same. In comparison to the people from the United States or the north part of Europe, they are a little bit reluctant to have a foreign body here for the beach, etc., etc. And then it's not so easy to convince them to have in-wheeling pleural catheter. And sometimes you say, no, I'm feeling very good. I have air in the pleural catheter. I see you in my mouth, etc., etc. Yeah, right. It's not, to have air in the pleural catheter, it's not a problem. If you have no lesion on the visceral pleura, it's not a problem. And I totally agree with this patient. Do not have something here. It's good if you don't have to make a puncture each week, etc. Okay. You have air. You have air. So it's cancer for a cancer. Other things to think about, chemotherapy, radiotherapy, and the life, etc., etc. But it's not it's personal view. It means it doesn't mean nothing. Patient 11? I don't know. I'm not tomorrow. I don't. Yeah, I don't know. I think it's 10 o'clock in the morning. I don't know. You have to. Actually, always Anson tomorrow. We have a full day of thoracoscopy with dogs.
followed by a cytoreductive surgery, and then followed by high-tech
So
cell
start
therapy.
as neoadjuvant
No,
high-tech.
not all patients.
No, I'm talking about the patient. It